This training, I've started the transcription as well. This training is a mashup of the training that I do across 2 semesters with when I train with Alverno and Marquette. So people have been asking for more trauma training, for more specific trauma techniques, and I thought, well, let's kick off the new year right. We'll get some of these on the books. I scheduled 2. I don't know if we're going to need more than 2. I am willing to keep doing trainings throughout, but one of the things we're going to do today is um, let's see, hang on, giving me little pop-up questions. Um, we're going to generate the topics that you all feel like you need most, and if I can provide those, great. If we need to bring in trainers, great. So we'll have that in a minute. So welcome everybody who's joining. I'm going to go ahead and start sharing the PowerPoint. Sorry, it's been a minute since I did a virtual training, but thanks for meeting virtually because that helps me just focus all my attention just on the screen instead of back and forth with in person and then screen. Um, I might have a little bit of difficulty seeing if something's in the chat as I go along. So feel free to unmute and holler out, or if somebody sees something in the chat, just if somebody can just read that out, if it looks like a question that's relevant for what we're talking about right then. But otherwise, I'll just plunge in. So this is a mashup. Um, I
Sorry, I didn't
developed
mean to interrupt, Mel. It's Nani. I'm here. I'm just assisting a client with the situation, but I'm here.
no worries, Nani. Thanks for being here this morning. Um, so there's a 2 course trauma trauma class that I taught at Alverno. It was a 1 course at Marquette. Um, Alverno used it as their trauma certificate. Been doing that for about, I don't even know, 10 plus years. So this is a mashup specifically for Benedict Center, and we'll adapt as we go, but launching in. So first, I just want to kind of hear about, and people can put in the chat or unmute and share, what trauma interventions are people familiar with already? Let me ask these questions one at a time. So, trauma interventions that you guys already feel like you have some good knowledge on. Just unmute and holler out, or somebody read out of the chat, please. Okay, the answer shouldn't be none. Let's get the participation going. Who is familiar with some
Lynette
trauma
said in
techniques?
the chat. Lynette said in the chat, breathing and grounding.
Breathing and grounding. Thank you. What else?
I sometimes let them like sit in their emotions and recognize how they feel. Can
Okay.
just let them be in that moment.
So, sort of sitting with strong feelings instead of trying to change them. Okay. Any trauma work, any trauma curricula that we already use? Okay. I want to come back to this question because I think we're doing more trauma work than we realize. But maybe at the end of today, we'll realize some of the things that we're doing that are actually trauma work that we're not necessarily identifying strictly as that. Let's move then to what trauma related topics do you need, you as a practitioner within Benedict Center, to feel more competent and confident in your work? All right. And I'm going to take notes. Oops.
Can
No,
you repeat
apparently I'm
that,
not.
Mel? Can you repeat the question? I'm sorry.
Yeah. What trauma topics do you need to have more information about to feel more confident and or competent in your particular role? Speak now or forever hold your peace. What do you wish for training as it pertains to working with traumatized clients?
De-escalation techniques.
Okay. What else?
I think like for me, like a lot of times in groups, something comes up we have limited time. So stuff that quicker ways to, I guess that's the thing. It's forget it. That's what Julia just said. But just in the immediate time to bring them back around to center on group.
Yep.
But lower the trauma response in that moment.
Yep. Okay. Good. Yep. Other things? Anything in the chat? Okay. We can add as we go along. My hopes for this process is to increase folks' knowledge of what might be a trauma impact or an impact from previous trauma in our day-to-day work with clients who have oftentimes a lot of symptomology, a lot of behaviors going on. What is the recovery process from trauma? And what are the best evidence-based practices, be it a group curriculum or different types of techniques that we could use even in a 3 to 5 minute sitting with a client. If you hear me say nothing else than this, the skills that we help clients learn about and practice are probably the most important trauma work we can do with a person who's gone through trauma. Not the deep processing, not the sharing their story, not the best. If we're only going to do one thing in all of their time with us, helping them acquire some skills to better self-regulate and manage their emotions and their lives it's foundational, right? Nothing else works if we're completely dysregulated emotionally. So sometimes we're thinking like, oh, well, this is just the basic work, and then I want to get to the real trauma work. I really, really strongly encourage you to internalize that the skills that we help them learn and practice is life-changing. I've had so many survivors come back later after the fact and say, when I learned that thing about breathing or that thing about grounding or that mindfulness technique, that was the thing that helped unlock all the rest of my healing process. Because we just can't get started when we're completely in a swirl of dysregulation. So the little things have very big impact. I also always say at the front end, trauma content, even talking about it, but especially if we use examples and get into it a little bit, that can be a little triggering for us as practitioners, whether we have a trauma history or not. So please do take care of yourselves as we go through this and as we go along. And in our work, always, we have to take care of ourselves first because we are the human beings through which the trauma work happens with clients. We are kind of an instrument in the intervention, and the relationship, the therapeutic relationship, whether with a case manager, a counselor, any kind of role, is actually part of the work because trauma wounds us in such an interpersonal way, especially if our trauma was interpersonal, which most of our clients have some interpersonal trauma on board. Lastly, and probably most importantly, our self-care strategies really need to be do as I do, not do as I say. So a lot of times people are drawn to doing helping work because they want to help other people heal the things that they may be also struggling with, but we can't shortcut and hop over also doing that work as, as our own person. And like, it's great practice to do these techniques because we can teach them better, but also because they will work on our trauma symptomology and our vicarious trauma symptomology. So it's a very active, we're doing it, we're teaching it, we're helping clients practice it. It's really important to walk the talk, as we say. Okay. So we use the word trauma a lot. It's it used to not be talked about a lot, and now in society, across social media, everybody kind of references trauma, and I'm traumatized, and this and that and the other. But I think it's really important to really define from a counseling perspective, what we mean by trauma. And the first author that I want to introduce y'all to is Dr. Judith Herman. She wrote a book, gosh, late 80s, I think it was, Trauma and Recovery. She's a psychiatrist, MD person, and what she did was look back over the previous writings in the field and really looked at how does the field deal with trauma? Because the PTSD diagnosis didn't even come into play until 1980. It wasn't until DSM-3 that we even had a diagnosis for trauma symptomology. And when she looked back over time, the places where we realized people were traumatized way back was almost always combat-related trauma. So people would come back from wars, be it World War II, Vietnam War, and they would see PTSD symptomology in large numbers of the service people returning back. There wasn't a diagnosis for it. There were words for it, things like shell shocked and stuff like that. But there wasn't really at that time identified treatments that were very helpful. And then she noted in her book that, interestingly, if you go a year or 2 or 5 out from their return, it's almost like as a field, we got it for the short term and then we'd forget it. We would move on like, oh, that was just a thing that we had to worry about when people were off to war and coming back. And it wasn't really until some of the work with rape crisis symptomology and response that we realized that, oh, wait, this trauma thing has some common symptomology no matter what types of traumatic experiences people have gone through. And that, wow, yes, this is not something that just happens every now and then when we go to war, but actually is a part and parcel of our everyday mental health lives. And many people have experienced at least one type of trauma in their life. Oops. So Herman really talked about the fact that when you're talking about somebody who's traumatized from an experience, it's a life-changing experience. So failing a test, probably not going to rise to the level of being a trauma. Even something like a divorce. Now, very upsetting, very distressing, could be a trauma if it's a life-changing experience that somebody can't recover from. But it's really not a word that we should be using for sort of everyday things that the person recovers naturally from. It really is narrowed in on experiences that render a person, at least temporarily, into a state of feeling helpless or powerless and overwhelms the systems that person had to cope, to give a sense of control, connection, and meaning. And those last three elements, control, connection, and meaning, are actually where we focus a lot of our healing interventions. So those are really important words that Herman identified for practitioners in the field. We certainly know a lot about different types of trauma that our clients may have experienced. For thinking about traumas that people have gone through and how to get started in helping them, I find it helpful to differentiate between single incident traumas and ongoing repeated traumas. So most of our clients may have layers of trauma that they've experienced across their lifespan so far. But a single incident trauma, you can have single incident trauma and ongoing and prolonged trauma. But if a person has never experienced any sort of traumatic experiences and they have a single incident trauma, in many ways the healing process is going to be a little bit more straightforward because they have a chunk of life lived beforehand where they had probably some pretty good coping strategies, they had a pretty good self-concept, they had pretty good support systems. Something happens, they're dysregulated for a time, and sometimes they're going to naturally resolve without any intervention whatsoever. That's actually the most common outcome. Not too many people who have a car accident develop full-blown PTSD, for example. Some people will, and depending on the elements of the car accident, some people would be more likely to. But single incident trauma has a different course of recovery than ongoing and prolonged trauma. This came home to me when most of the people I've worked with have childhood trauma and or layers of trauma. But when I was at the Healing Center, I had somebody come through the programming. She had never had any significant traumatic experiences. She's about 35 years old. She was sexually assaulted by a coworker and was completely discombobulated from the experience, understandably. We worked with her in individual counseling for a few sessions, helped her really get, she was doing a lot of self-blaming, it was my fault, because we were able to pretty quickly reverse the erroneous thinking that she was doing and get some supports in place. She did a support group. She did some individual sessions. Her recovery path and process she was completely back to full confidence and functioning within that 3-month process. And really, she never met the clinical diagnosis for PTSD. She got help right away, which is great. Not so many people don't, but she did, and never even developed full-blown PTSD. So we'll talk about that in a minute. But single incident traumas. Question? Oh, maybe not. Are very different than ongoing or prolonged trauma, which has more and longer and deeper impacts, especially if they happen younger and in childhood, because our sense of self is not fully developed in childhood. We don't have as many, we don't have as much perspective. We have virtually no protective factors in and of ourselves. Nope, somebody needs to mute. We don't have our own ability to be self-protective, so we're really reliant on our caregivers and other people in our surroundings to protect. So there's a lot more that becomes internalized, is the word we use in the field. We internalize all sorts of things from trauma, and when it's ongoing and prolonged, it's just like if you think about it as like acid rain, it's sort of soaking into us and has longer time to soak in and get deeper into all senses of ourself. And we're going to talk about that as we talk about healing. Additional categories. There's the trauma that we go through, and that includes community and historical trauma. And then there's the trauma that can come in the process of trying to help seek after a trauma. So if somebody experiences, a physical assault, let's say, and then they turn and try to report that to the police, and then the police are very blaming and shaming about the situation, or treat the person like their assault doesn't matter, or don't even respond, don't even show up when they call for help. That sort of like failure by systems that should be helping in some kind of way. Could be a doctor, it could be a medical system, could be law enforcement, could be the DA's office, can be therapists and counselors. I've had clients who they were hurt by a trauma, an interpersonal trauma, but the thing that they couldn't get past is the wounding that happened when a counselor or a social worker said, well, you do realize this is kind of your fault because you were drinking, or that you do realize that you put yourself in harm's way. Basically communicating blaming messages of this wouldn't have happened if you hadn't done something wrong. And they really have then a compounded trauma of the original situation and the kind of wounding that happens when you are in a vulnerable place, you ask and seek help, and then the help basically just piles on. All right. So this is participation time. What do you think makes some types of trauma worse for the survivor than other types of trauma? And just unmute and holler out. Gal?
I think it really depends on the age that the trauma happens. Maybe some
Okay.
self-resilience that you might have or not have.
Okay. Do you think it helps to be older or younger?
It's not always the case, but I think when you're younger, it might be worse, as you said.
Okay. Yep. We
I
have
think if
less
you weren't-
resources. Go ahead, Beth.
If you weren't believed,
Yeah.
people
So
questioned what happened or
yeah. So the response, absolutely. If we don't get a supportive response, that makes it worse. Yep. Kathleen?
I'm thinking just if you were tortured, that would make it worse than others versus being in a car accident.
Yeah, yeah. Okay. So the element of severity, right, is within that. And also who the person is. Is it a person or is it like a tornado? Like, is it because it's hard to have an interpersonal trauma that doesn't feel personal, right? I think Nicole, you popped in as well with a hand. What you got?
I would say maybe like the location. Is it something that happened in a place that you thought was a safe space, for example, in your home, or is it something that happened out in public where you couldn't necessarily rely on your safety anyway?
Yeah, good point. Yeah. Did it happen in something that previously felt like your safe haven, your safe space? Yeah. Okay. Good. Any other thoughts? All right. You guys are on the track of some really important stuff, right? So we've got some elements that research has shown increase the likelihood of lasting traumatic harm. And two of the categories that are most recognized to produce ongoing PTSD are combat, like life-threatening combat trauma and sexual violence, rape and sexual assault, and ongoing childhood abuse. So these elements of, first of all, there's some sort of actual or very deeply threatened personal violation, physical violation of the person. The element of surprise can really increase because like there are a lot of survivors that like because they felt like they got caught off guard, it's like they never trust their environment again, or they don't even trust themselves to see the threats coming. Sometimes the element is feeling very trapped, like I couldn't save myself, I couldn't get away, and that includes being trapped in childhood, in our families potentially. Like if the abuse is in our homes and we can't figure out any source of escape, and we aren't being protected, that is absolutely a feeling of being trapped that would contribute to the amount of traumatization that a person experiences. Being exposed to the point of exhaustion. There's something that can happen when people are held, and Kathleen's example was like being tortured. There's often a place, a sort of a point where we just are so exhausted that we kind of give up and surrender to this idea like I'm not going to survive or I'm not going to be able to get out of this situation. And it changes us on the inside a little bit. I've worked with some folks who hit that point thought they were going to die or thought they would never get out of the abusive situation. And it took them a good long while to kind of reinvest in living and being alive. They were sort of quasi-suicidal for a long time, um, because it was like they made peace with the fact that they weren't going to survive. And it's like you sort of, it changes you a little bit. I haven't seen that element studied a lot, but it definitely is an element for some people in their healing journey. Violence or injury, especially lasting violence and injury, where the survivor is going to be seeing those impacts. That includes like we've got some clients that different types of experiences may have left them living with like an ongoing illness or disease. Basically, when you have the reminders of the incident over and over again, kind of in your face, that adds an element to the healing process. And if resistance or escape is impossible, or they try to fight or resist and they're unable to, let's skip to a different piece here. Factors in healing. And sorry, I'm going to just be sharing and resharing the screen. All right. So when we think about trauma and a person's ability to heal, we really talk about internal individual factors and their environment. And the things that I want to talk a little bit about, the things that can make things worse and the things that can make things a little better. Now, when we're working with somebody, like you might be wondering, like, how does this all factor into how we're helping them? And for me, what I want to do when I'm trying to work with somebody is understand the context of what they're sharing with me, so that they don't have to tell me everything. I have some like in the back of my mind context that I can then ask some clarifying questions if needed. But the more we can understand how different types of trauma impact people differently, then we can be a little bit more helpful, because we don't have to rely on the client to tell us every single thing in order to help us understand. So that's kind of the reason I go into this context part. So when there's repeated incidents, obviously we talked about that, more severe abuse, and you know, it's ironic that we're talking this way, because in the work we talk about the fact that there's no hierarchy of pain. Like a client might come to you and have very minimal severity of abuse, but be highly traumatized because of their own context and how they experienced it. So we don't want to be like, well, your abuse was less severe, so therefore you're less traumatized. So sorry about that. But this is just in general. So these are like generalizations that we don't ever want to apply to any individual person specifically. But the severity of the abuse, the amount of pain inflicted, or the threat of like loss of life tends to increase the intensity of the symptomology, the duration of the abuse, the physical violation, fear of injury or death. And then we touched on this a little bit. If our safe space is violated, and or if the person that's doing the perpetration of the violence or trauma is a trusted person to us. So domestic violence is particularly impactful, because you're on the one hand, it's a person who's supposed to love you and saying that they love you and you love them, and yet sometimes they're doing these horrible abusive things. So it's like that trusted bond means that the internalization of the abuse kind of immediately bypasses all of our defenses that we might have up if it were, say, a stranger or somebody who was a little less in our trusted sphere, they're in our circle of trusted influence, and yet they are doing these horrible things to us. We also touched on if the response is unsupportive and or punishing, blaming, discounting, that can be very, very traumatizing to people. The age, the younger the victim, the more vulnerability and the less resource internally. But let's also talk about the things that help, because all of us are in the helping role. The things that are most helpful in dealing with trauma is first and foremost accurate information. So we tend to get into a lot of erroneous thinking when we experience a trauma. And to have somebody who's a support person on the outside kind of gently pointing out when we are being either too hard on ourselves or taking responsibility for something that wasn't really our responsibility. So that sort of like mirroring of like reality and more clear thought can be really helpful. Also, accurate information about what helps. People don't usually have some sort of roadmap for, I went through this, how do I heal from this? Like, we go to if we go to the hospital and we've broken our leg or got hit by a car and we have some tissue damage, things like that. When you get checked out of the hospital, you have this like multi-page, here's the plan for follow-up. Here's the things you need to be doing to heal from this experience. You need to be maybe doing some physical therapy or elevating your leg or taking this and that medication. People who experience interpersonal traumas are usually trying to deal with them on their own. They're not necessarily telling many people because they feel a sense of shame or vulnerability, and they don't have that blueprint for how do I go about working on this. And this is what we do. We help people at least understand the menu of options for how do I do this work. We provide a lot of emotional support, and it's so important that the emotional support is absolutely non-judgmental, very compassionate, very non-judgmental, because people who've gone through trauma are very susceptible to, they're already doing self-blame. And so even a statement that's pretty neutral can sound unintentionally victim blaming. So we want to be really careful about that. We want to validate their feelings, any and all feelings. It's like the fact that they're having those feelings, we want to validate them. And we want to help them understand that if, let's say that they are self-loathing, that feeling is often coming from some sort of taking on responsibility for something that happened that is probably more complete than it should be. Like, where's the abuser in all of that? Like, sometimes we do an exercise called accountability pie, like a pie graph. And I've had so many survivors of interpersonal trauma when we ask the question, who is responsible for the abuse elements, the physical assault or the sexual assault, those elements, they will put themselves and non-protective family members all over the pie. And sometimes they forget to put the actual abuser in the pie of accountability at all. And sometimes it's like the abuser only gets like this tiny little pie slice. So sort of sorting through and sifting through how much responsibility does any particular person have? And, what was that context? Did you really have the power to stop that from happening? So I've had people who were adult survivors of child abuse just swear up and down that they had the power to stop an adult abusing them, even though they were like 4, 5, 7 years old at the time. There's a hindsight bias that we oftentimes are trying to work against and help people understand a little differently. And then encouragement, empowerment, and then helpful strategies. That's really where all of our stage 1 work is going to come in, is helpful strategies to cope and deal with emotions. So I just wanted to share that. And I'll send these these little information pieces out when I get you guys the slides too. So all right, now let me get back to my PowerPoint. Any questions while we're switching over? Okay. All right. Can't this go forward? There. All right. So in the DSM, like I said, trauma really didn't even show up until DSM-3. We're now on DSM-5. They tightened up the definition of trauma a little bit, in that they had broadened it out that you could witness from afar and still be traumatized. And that actually is true. They did some studies after 9/11, and the people watching the aftermath of 9/11 with the buildings burning and collapsing and people jumping from the buildings, people experienced symptomology that was at the diagnostic clinical level just from watching all of that on TV. So much so that I forget, it's like the Society for the Study of Traumatic Stress or something like that. They actually worked with a lot of the major news media and really encouraged them not to show those kinds of videos and imagery in the aftermath of serious traumas, traumatic incidents, because when they broadcast that stuff, it can harm people, basically. So you can develop symptomology from watching horrible things, let's put it that way. But for the tightened definition, they shifted it to witnessing in person a traumatic event that happens to someone else or experiencing it directly. And they really hone in on exposure to actual or threatened death, serious injury, or sexual violence in various ways. So they're really, I think they're trying to kind of get it a little bit more honed in. Also, that learning a close family member or friend has gone through some horrible things, or experiencing repeated and intense exposure to details through professional duties. And so that's us. It's also first responders like, EMS, EMTs, fire police, but we also are sometimes exposed to a lot of intense details through our professional duties, and we can develop, as we know, some traumatic symptomology from that. In the most recent DSM, they took PTSD out of the anxiety bucket and created a kind of a whole trauma bucket of its own, trauma and stress related disorders. And there's a couple that are more diagnosed in childhood: reactive attachment disorder and disinhibited social engagement. So I don't want to go into a lot on them, but the understanding of attachment is really important in trauma work, not only for children though, but also for adults, because how we experienced ruptures in healthy and safe attachment in childhood tends to have echoes into our ability to trust and connect in adulthood. So the more that we can know about healthy attachment, kind of the better, in terms of it helps us understand what people need to heal and areas where they might struggle with interpersonal functioning. But that's more for another day. In trauma work, if we're diagnosing, if you experience a trauma today, you have 3 days where you're going to be discombobulated naturally, right? Because it's an overwhelming and potentially life-altering event. And you're gonna experience some of the symptomology that looks like PTSD or looks like acute stress disorder, but you can't even diagnose it in those first 72 hours because they recognize that human beings, when they go through stuff, of course, are discombobulated for a bit. And what we're looking for is, does that like sense of overwhelm and I don't know what I'm doing and I'm having all these emotions, does that resolve naturally within approximately 3 days? If it's not, if it's staying the same or getting worse, then we're looking at a diagnosis of acute stress disorder. The symptomology is essentially looks like PTSD, but acute stress disorder is used when it's been 3 days up to 30 days. So it's short term. This is the diagnosis that they use at the hospital when they're seeing a sexual assault victim. Acute stress disorder. It just happened. They're very discombobulated. They have PTSD looking symptomology, but it's only been within 3 and 30 days. If it's been more than 30 days, then we're looking at whether or not they meet the criteria for PTSD. You can't diagnose PTSD on day 22. That's got to be acute stress disorder. And acute stress disorder shouldn't be diagnosed 6 months down the road. It's PTSD. And then adjustment disorders are kind of nestled in between because when something has happened and the symptomology might be similar to acute stress disorder, PTSD, but doesn't meet all the criteria, but you need to diagnose something, a lot of times we'll use an adjustment disorder. And adjustment disorders are like something happened within the past 6 months and the person is dysregulated in their behaviors or their feelings or their anxiety, right? It's like gives you a few options to talk about what the symptomology is, but it talks about the fact that they're having a difficulty adjusting to something that happened. And then for certain situations, prolonged grief disorder fits or some sort of dissociative diagnosis. But these are kind of the big few that we utilize for diagnosis. Symptomology, some of it is around the hyperarousal category, where a lot of intrusive events, a lot of intrusive memories, they're trying not to think about it, but it's still coming up, nightmares and terrible dreams, intense physical distress, including a lot of GI impacts and things like that we're going to talk about in a minute, and the avoidance element of I'm trying not to think about it, I'm trying not to deal with it, I don't want to go around that person, I don't want to go out of the house. So a lot of different symptomology, also dissociative type symptom where we're numbing out, either numbing out mentally or this is where substances come in so strong. People will self-medicate to try to soothe this intensity of symptomology and try to numb out chemically when they aren't able to like bring that hyperarousal level down on their own. Sometimes feeling detached or estranged from others, feeling very different, feeling kind of almost like in a zombie-like state sometimes. Difficulty with sleep is really common. Hypervigilance is really common. So a lot of this stuff, I think, is what we commonly know of as PTSD or trauma type symptoms. As we're listening to our client, these are the things that we should be kind of taking note of, like as you're doing an assessment or as you're talking, somebody's sharing their story with you. These are the things I'm filing away in my little mental filing cabinet. What was the frequency of their traumatic exposure? Is this single incident or is this, layers and layers and layers? And unfortunately, layers and layers is more common And sometimes it's like, oh, they had layers and layers, and there's a single incident that's more recent that's kind of stirring this all up again. Where were they at in their development? Is it childhood, teen, adult? Was it interpersonal trauma, or I just used the word impersonal trauma? So, like, was it a car accident? Was it a tornado? Was it hurricane that, you know, devastated the family home? Even if it's impersonal, it can be very affecting. But if it's one of those interpersonal traumas, then we know that, oh, we got a whole bunch of other elements that we have to deal with as well. And what was the protective response? Was there a protective response? And who, what, and did it work? And then I always like to find out what their own efforts have been toward healing or resolving the situation thus far. And a lot of people will tell me, "Oh, I just try not to think about it." Or, well, that's when I started really increasing my substance use to try to sleep, to try to soothe, whatever. Like, it's very interesting to hear from people what they feel like they've tried to do to deal with whatever the trauma is that they're telling us about. And just kind of like, most people do try to do stuff. It's very rare for somebody to try to do nothing. So I always ask that question somewhere in the assessment process of like, well, so what have you tried so far? When we're looking at the impacts, especially of interpersonal trauma, I kind of think about it, it does affect every aspect of ourself. So for me, it helps to kind of put that into certain categories. The emotional impacts, and these lists are not exhaustive. And I'll get you a copy of these slides, so don't feel like you need to be trying to catch all these details. The emotional impacts are usually some of the most important things that people are presenting with. Their emotions are running them ragged. The mental impacts almost get taken for granted a lot. And clients will argue that, the way that they think about themselves, other people in the world, are just facts. So it's why we do a lot of cognitive work around some of this what they've decided is true. Behavioral impacts are the things that get people sent to us. It's the things that get people in trouble, basically, sometimes. Like the substance use can get people sent to us, the doing criminal behavior can get people sent to us. And in the mental health system, self-injury, suicide attempts, basically, like the behavioral stuff is what gets people flagged for some sort of intervention, or they self-refer because whatever those behavioral strategies are have sort of ceased to be helpful. So I want us to take a long look at this list, because all of these behaviors should set off an alarm bell in our head that says, I wonder if this person has a significant trauma history. So some of these things are behaviors that society judges quite harshly, right? But all of these are behaviors that grow out of having experienced unresolved trauma. And they all behaviors make sense when we really understand the context of a person's trauma history and their strategies that they've used to survive. So I said, if there's one thing that you take away, it's that the coping skills and things like that we give folks are life transformational. The other thing I want you to remember, if nothing else, is that all behavior makes sense if we really understand the context. And that's all behavior. Even behavior that on the face of it's like, I don't understand why this person keeps doing this self-destructive thing. Well, it makes sense if we think about it with our trauma lens on. So I just want to plant that seed right there. A lot of physical impacts from trauma itself, and especially then we learned with the ACE study, which we'll talk about probably in the next session, that we experience the trauma, we have some dysregulated internal systems. Then we do some high risk behaviors, is what they call it in the research. But basically, we do the things that we think are going to help us self-soothe, and then those things like smoking, drinking, you know, actually then can develop or worsen our physical health as well. But even just without those health risk behaviors, they've studied survivors of particularly childhood trauma, and if we haven't, and I really think it's interesting because they've studied mostly people who haven't really done a lot of their healing work. So the part that gives me hope is that, like, if we do our healing work, we decrease the fight or flight PTSD symptomology, which then decreases the impact on our bodies. But we know that if we are in that fight or flight flood of chemicals over and over again every day, it takes a big toll on our bodies over time. And then spiritual impacts, which we don't talk about a lot in psychology, but you could call them spiritual, you could call them existential, whatever language you're most comfortable with. But there is this element of, like, why do bad things happen in the world? Why me? Why did these bad things happen to me? Why didn't anybody help me or save me or protect me? And if somebody has a sense of, you know, higher power, spirituality, it's really pretty important to understand whether or not they feel supported by that sense of spirituality or judged by that sense of spirituality. Because it can be a huge protective factor and a huge resource. And it also can be another piling on of experience of judgment and stuff like that. So in trauma work, we really are trying to figure out how the person sees and lives in the world. Do they have a positive or negative sense of self and self-esteem? Positive or negative view of other people, and positive or negative view of the world, the safety of the world. Woo, so that's a lot. Where do we start? How do we get started effectively and safely? Let's take a little pause. I'll also, while I'm shifting over, any questions or comments that you want to add in at that point for other people to understand? A lot of wisdom in this room, I know already. Okay. I'm going to share with you a little roadmap that, oh, I'm so weirdly in shadow here. I didn't notice that. This is a little cheat sheet that I did up for first for my Healing Center team, and then I share it with all my students too. And there most of the theories and approaches to trauma work use this 3-stage model of healing, and they call it different things in different researchers, whatever, call it different things. But the most important thing to understand is that the first stage of the work is very much safety, stabilization, and psychoeducation. Stage 2 is where we get into our processing, our trauma processing, our processing of the deeper emotions, the thoughts, all that kind of stuff. And then stage 3 is really sort of this, having done all of that primary work, how do I bring it all together in my life, make sense of this big thing, and then be moving forward into my life? So, you know, it almost doesn't matter what we call it, but it is helpful to figure out what stage is the client in, because that dictates what the most helpful work will be. All right. So most of our clients are needing some stage 1 work. And what does that mean? Like, they're coming in, they have a lot of observable symptomology. Maybe it's a lot of PTSD symptomology. Maybe it's a lot of depressive symptomology. Maybe it's a lot of acting out symptomology, but they got a lot of stuff going on that is behavioral and observable in their world. And they probably don't have a whole lot of stability going on. And that means stable life, stable internal feelings, stable relationships. So oftentimes we need to be at least checking in and starting with the presumption that we might have some stage 1 work to do. Now, I call these things healing tasks. This is like, what's the client working on, but also really tasks for the case manager, the counselor. Like, this is what are we bringing to the client in stage 1? We are bringing obviously the rapport building, actively voicing reassurance and encouragement. We are validating feelings. We also hopefully are given a little psychoeducation about what we're offering, how it might be helpful. I never promise things. I just say this could be helpful, and here's how it could be helpful. We are often doing, especially if we're counselors, but everybody's doing some level of assessment and or screenings. We are hopefully addressing environmental safety issues. That could be community safety, it could be in the house safety, it could be DV safety, it could be dealing with strong emotion safety is a kind of a key aspect of stage 1. We are doing some goal setting, we are doing some psychoeducation, and I think we sometimes are a little bit more like we're explaining, okay, you need to do this, this, and this in order to get through your DPA or get off your supervision, or while you're here at the CRC, it's this, this, and this. I don't want us to overlook if we're doing that work and somebody's talking to us about some bad things they've gone through, some traumas that they're living with, helping to demystify, how do I work on this issue? Even if they don't do the work with you, even if they can't do the work, even if they're like, oh, I'm at the CRC and I'm getting out in 2 days. Oh, but and they say they're talking to you about these real hard things. Planting that seed for how to work on that issue post-release, or once you feel more stable, here's something that might be helpful, is really important, because like I said, people don't have a mental roadmap about, how do I work on this stuff? How do I heal from these things? Oops. So that can be I would call it an intervention. Psychoeducation to me is a really important intervention. And we want to be thinking about, like, what does this client need to know in order to empower their healing journey? And then we get into a whole bunch of skills. So depending on how much time we have with someone, how many times we're going to see them, we could give them all kinds of information about helpful skills. And sometimes people are like, well, I'm only going to see them. I had somebody say, well, we only see people for 60 days. And I'm like, oh my God, 60 days is a long time to give lots of skills and information, really. Like grounding skills, any kind of affect regulation skills, any kind of emotional management skills. How to self-soothe. Even if it's like, hey, do you know about this app that does a guided imageries? I mean, there's so many things out there. You can't do it all, but find the 5 or so skills that you are most comfortable sharing and talking about with the clients, and put those tools in their toolbox. That's a great metaphor, great image. Help put these tools in the client's toolbox. Acknowledge that, like, hey, what works for me may not work for you, but these are skills that survivors of this type of trauma have found helpful. So let's use that air of experimentation, and each client should try things out and see what works for them, because we all end up making kind of a patchwork quilt of what works for us. Some of these skills we're going to talk about more specifically, so I'm going to leave those there. Let's see, putting goals in. Okay. Stage 2, I'm going to talk about stage 1 and stage 2 really specifically, because I want you to be able to start to discern the difference. In stage 2, you're still doing these little dots mean you're still doing this stuff, but you are going deeper with what can be considered exploring, discussing, and processing. All right. So maybe in stage one, we're teaching grounding skills and they're practicing grounding skills. In stage two, what we'd want to see is that the client is actively practicing grounding at home on their own with some success. That means they've internalized that skill a bit, that they're able to name and safely express feelings. Whereas in stage one, they might or might not be able to even name the feelings that are sort of a swirl and overwhelming, but they probably are not necessarily safely expressing. And by safely, I mean they can express it without becoming destabilized and dysregulated and or hurting themselves or someone else. They're actively practicing some good coping skills, self-soothing skills. And then we're getting into this like examining the ways that the abuse, usually I'm talking interpersonal here. If it's interpersonal trauma, they're actively sifting through, how was I impacted by this abuse? What parts did I internalize that I'm still struggling with? How am I starting to not fully make sense of it yet, but challenge the self-defeating thoughts and beliefs that maybe I've believed automatically for a long time, but with the help of the providers, like rethinking that. I kind of think of it like we're shining the light of day with our adult self, looking at these thoughts and beliefs that maybe we believed from the abuser or from the experience, and deciding whether or not those were really true and whether or not they're still true. We're also working to identify safe support people and good community support. And a lot of survivors of, especially if the abuse was in the home, survivors need a lot of work around boundaries, because I've had so many survivors just be like, well, yeah, I have to go home for the holidays, or I have to still see my abuser. And I'm like, that's an interesting word, have to, or you're right, like I have to. A survivor who's an adult today who doesn't live with their abusive family anymore, who says I have to see them, do they still feel that sense of being trapped, even if they're not actually still trapped, right? So working on whether or not they can set some boundaries differently. I mean, it's really safety planning in a way, emotional safety planning especially, but like we're challenging old assumptions there, right? So boundaries and safety with others. We're working on the ability to talk about the traumatic content without getting swamped into it. And we're doing healthy, fun things. We're releasing stuff that no longer serves us, and we're figuring out what's been keeping me stuck and doing different things. Oops, Nani, I see that you're calling me. Is Nani on here? Did she get knocked off? What's happening? Gabby, can you work with Nani? Is Gabby on here? Yeah. Maybe she's got a client situation going on. I'm not sure. I'm not going to pick up that call, but if somebody can touch base with Nani, that would be great. Sorry, just looking real quick. Nope. Okay. Questions, comments? Is this helpful? Is it too, I mean, this is the big picture roadmap. What are y'all thinking about it so far?
It's helpful.
Okay, Kathy says, yeah, helpful. Gall, your hands up. What you got?
I think it's really helpful, especially that we work so much with trauma and we, as you said, like we don't realize how much we work with trauma and we actually do those things. So it is helpful. I'm sure you can't summarize a full course semester to like an hour, not even. But so I'm excited for more. That's why I also
Yeah.
requested it. But I
Yep.
also have a question. It's not really related to what you presented, but it's just
Okay.
like in general. Um, could you do a diagnosis for PTSD for a person who immigrated from country to country? Nothing really traumatic happened in this like scenario, but they feeling feelings of disassociation, flashbacks, due to the disconnection from the roots of the country coming to a new one, like, and all that encompasses that. Could you define it as trauma, or would you say it's something else?
Yeah. So that's a great question. The the nutshell is there's how you conceptualize it in session with the client, like how we talk about it with the client, how we think about it as a treatment team, and then what could or would we diagnose it as using the DSM, right? The DSM is the most strict of what we can define as trauma because it's going to say it has to have these elements, right? Sometimes clients have a whole bunch of trauma symptomology, but they're not remembering or not sharing or not willing to talk about the actual things they've gone through. So when you say, like you said, clients having flashbacks, that's interesting, right? Flashing back to what? Experience. And sometimes they're just not saying the thing, but which also makes it hard to diagnose because we'll talk about this with assessment. It's like we do assessment at the very front end of the process when clients have the least sense of safety with us and no rapport and trust established yet. So they're going to give us only usually limited information. That's why we think about assessment as an ongoing process. So for me, whether or not they fully meet a diagnosis is important, but less important of what is the work we need to do, right? So if a client, if we gave that client the PTSD checklist, she might be all over the place. She might have a really high PTSD score. We might not, when we look at the DSM, we might not be able to diagnose PTSD if we can't meet some of those criteria. But if she's got a very high PTSD score, she will probably benefit from the work, right? Does that answer your question a little bit? Yeah. Okay. Let me just pop back and I'm going to send you guys out this thing so you'll have this all, but I just also want to draw attention to the the bottom half of this document. And what I've compiled here is not everything, but some of the types of curricula, modalities, interventions. Lynette, honey, can you mute? We're catching your background noise there. She's not my Debbie pants. I'll try to mute her. Hang on. Oh, I can't because I'm sharing. All right. So just to summarize some of the different possibilities that one could use or connect a client to, like there's a lot of stuff, right? Like how do we even make, okay, what groups should a client be in with us or in CCS or whatever? Like, how do we make great recommendations based on what the client, not only, or they go, oh, they've been traumatized. Great. There's a million different directions they might go in. But if we know, wow, they've been traumatized in childhood, they are still needing a lot of stage 1 work, then we might really want to go, okay, definitely some CBT. Maybe they're ready for DBT. You know, getting into like which things are going to be the most helpful, whether we provide them or we just help the client understand what that work could be and where and how they might do it. We can't do it all. We might not even, it might be beyond our scope of practice to do it with the client. Like, you know, if we're not a counselor and we've never had any training in DBT, we probably shouldn't be doing DBT stuff with clients. But we might go, hey, this client is I'm seeing them one-on-one. We've got a DBT skills group. Let's enroll them in the DBT skills group, right? So it's figuring out what might be helpful, what is the client interested in doing, willing to do, and then implementing that into their work. Okay. I just wanted to share that this document also kind of gives some ideas on what type of work people could do. Back to our show. All right. Are we back? Are you seeing the PowerPoint again? Somebody?
Yes.
Yes.
Thank you. Okay. So summarizing, this is just a quickie summarization of like, what are we trying to do in each of the 3 stages? And we've talked a lot about stages 1 and 2, but in stage 3, just as a quickie, you know, the work's not done, but it's because instead of being really hyper focused on like, oh, I'm in this, I'm struggling every day, I'm figuring this stuff out. It's like there's enough success that we kind of start to like think about bigger life past this moment, life down the road. Who am I now? What do I want for my future? Right? With some anxiety, some excitement, and more excitement, less anxiety, more positive connections, less toxic or destructive connections. And this is stage 3 is where conversations about post-traumatic growth fit nicely. Sometimes people bring up like, should we be talking about post-traumatic growth and all the benefits or the silver lining of going through trauma? I don't advise that in stage 1 at all. And I would say not until pretty solid amount of stage 2 work has happened, because survivors will react really negatively to it, and it comes across really as us trying to hurry people through a process, rather than letting them do the work that they need to in each stage. What does it mean to be a trauma-informed agency? Like trauma-informed care, a lot of trainings, we've gone through trauma-informed care training. And so sometimes people will be like, oh, I do trauma-informed care. And I go, okay, well, what does that mean? And then they kind of can't really exactly say what that means. Because trauma-informed care is really about how the agency and a practitioner, the values that we hold as we do whatever work we do. It's not an intervention per se. It's not a treatment approach fully per se. It's about the values that we bring into our space and into our relationship with the client. So very quickly, I mean, the original TIC values are on the left, and what those sort of have evolved into more recently are on the right. That's probably a whole other deep discussion. But I will send out, when I send out the slides, I'll send out kind of like, there's an agency audit that looks into these things a little bit more closely, and you can see examples of what each means. Okay. Getting into this psychoeducational idea, like what does a average client need to know about trauma? Well, what do we need to know if I'm coming in the door and I have, you're thinking, oh, this person seems like they've really got a lot of trauma. They've gone through a lot, and they have a whole lot of trauma symptoms and impacts, what do we need to be pointing out to the client? Maybe it could be nothing, but I always wonder, does the client realize that a lot of their symptomology stems back to the trauma that they're experiencing in the current day or in the past? How does it relate to what the client is help seeking about? If we're embarking on some sort of process with them where let's say they're signing up to be in seeking safety, what should we be letting them know the potential benefits are of that? And is there anything that we need to warn them about? And in trauma work, as in counseling, there's this idea that we say, oh, you might feel worse before you feel better, right? That's real common language around, I'm entering into counseling. You might feel worse before you feel better, but it has a lot of potential positive benefits, blah, blah, blah. If the client has been really stuffing, suppressing, dissociating, numbing out their trauma impacts and symptomology, and then we start focusing on it directly, that is true. They might start to be thinking about the traumatic events more. They might dream about them more or have nightmares. They might, basically, it's like but more in the forefront of their attentional space. But if they're already overwhelmed with all their trauma feelings and emotions, and like if they're just kind of walking around with a swirl of it all the time, actually, when we start to deal with it and address it directly, they don't have often an increase in that. They actually start to feel a little bit of a stabilization and a reduction right away, because it's like, oh, I finally have a sense of hope that somebody's helping me with this and we're doing something to make it a little better. So it really depends on how present the symptomology is for the client, whether or not they're going to feel worse before they feel better. And every person's different. So it's like, I just try to plant the seed at the front end that we want to go at the pace that the client can go in without getting more overwhelmed and without getting overwhelmed from the work itself. So that's the big picture. And we'll talk a little bit about that with assessment and collaboration. Things that all of us should be paying attention to as we're dealing with a client is, are they in a state of what we'd call hyperarousal? Are they in the fight or flight kind of mode? Because if they are, we should not be doing any kind of trying to get our agenda across or cover group content or, accomplish what we wanted to accomplish in the session. If we're in a state of hyperarousal or flashback, the only thing we should be working on is helping the client ground, get back into the here and now, and bring down the intensity of their affective and physiological state. On the flip side, sometimes clients are in more constriction or dissociation mode, and sometimes that can look like they're less upset, right? Because hyperarousal, you see it. On the constriction dissociation side, they can be very compliant, very like we're talking to them and they're going through like an assessment or a group, and they're just they're quiet, they're just there, like, but are they really there? Are they attuned? Are they attending? Are they responding? Or are they somewhat checked out? So I wanted to give both sides of that equation, but because all of that is red flags that the person is not very mindfully present in the here and now. And what'll happen when we go into stuff when the clients are checked out or somewhat dissociated, we might talk over a lot of good things in the group or in our individual session with them. If you've worked with somebody and you're like, oh, we went over all the different steps that they need to do for reaching out for this case management thing. And then the client comes in the very next time and it's as if it's as if they were never there. Like, I don't remember that. Nope. Who? What was I supposed to do? Like, sometimes we're talking to them and we're thinking that the information's going in and getting stored, and it never got stored. So this is a little constriction and dissociation are a little bit harder to see and notice. And really where you're going to get it is whether or not they're responding, whether or not they seem to be tracking and following the conversation. So checking in, what are you hearing? Tell me that back, that's where we're going to figure it out a little bit more closely. All right. I wanted to kind of summarize some short, helpful skills that any of us can use internally, any of us can share with clients, and counselors in particular can use them and then practice them in session and then make it part of the processing if clients are in stage 2, some of this stuff. But breathing retraining is a stage 1 intervention. It's good to expose every client to box breathing. Every client. Now, some of them will get it. Some of them will practice it. Some of them will not. But that's okay, because this is like one of those, a skill that people can do anytime, anywhere, without anybody knowing. And there are videos that can guide them through it as well. You don't have to learn how to teach it. You can just put the video on a phone, on their phone, and they can learn how to practice this. Why do it? Well, it immediately helps shift from fight or flight into more so the parasympathetic response. So if you want clients to be able to help calm more readily, box breathing is a tool in the toolbox. So you got a link there for that. Safe place visualization sounds like something we would do with them as a group activity or an individual activity. But I also want to plant the seed that being able to create a mental imagery of a safe place, doing that work with someone or doing it via a video and kind of coming up with borrowing somebody else's safe place visual. It doesn't really matter if it's their own construction or a video that they resonate with. Being able to mentally go there when they are under stress is, again, something they can do anywhere, anytime, at 3 a.m. Going, I'm going to go mentally, I'm going to go to my safe place. Poof. And they can do it. And when we go into a mental imagery of a safer place and environment, it actually, our bodies and physiology and emotions react as if we've relocated ourselves. Trauma, our brains have no sense of time and no sense of space, but what we're giving them. So time is an artificial construct. But if we are mentally really fully seeing this safe place visualization, we will feel safer. So it's a big tool in the toolbox. Containering is, how do I hold the emotions, memories, whatever, from traumatic events? How do I hold them in a safe way so that they're not overwhelming me, especially like between sessions or something like that, or if it's just so overwhelming I can't even get started. So that the thing that I've got there, for a link for you, is a guided sort of introduction to the container method, that you could show a client, you could watch it together, and then they come up with their container image of a strength vessel that can hold their traumatic content. So each of these is really short. So I encourage you to watch each of them and kind of see what it's all about, and see which ones you might already use and which ones you might find helpful for clients. And then lastly, but not leastly, there's some vagus nerve strategies that kind of fall under the element of somatic experiencing. Peter Levine has been a very innovative practitioner, researcher, author in this. So there's a couple different videos that give some concrete ways that clients can activate that vagus nerve. And again, it's when we activate our vagus nerve, we're initiating the parasympathetic response that helps us go from fight or flight to resting and calming. All right. So these are all very practical and short skills that we can use with clients and or give and teach to clients so that they can do them via these video links without us even being in the room with them. Okay, I am going to stop the recording and stuff so that we can